Good evening, everyone. My name is Kerry Chan, and I'm the manager of corporate communications and public affairs for the BC Dental Association. On behalf of the BCDA and our co-presenters, the Dental Hygienists Association of BC, we thank you for attending our webinar, The Effect of COVID-19 on Oral Health of Elders Living in Long-Term Care. It's my pleasure to introduce Dr. Salima Dadani, who is BCDA's Director of Member Support, who will be acting as tonight's moderator. And with that, I will turn it over to Dr. Dadani.
Thanks, Carrie. Thanks, everyone, for joining. As Carrie mentioned, this is a collaboration between the BCDA and the BCDHA, and really wanted to thank the BC Dental Hygienists Association for all of their contributions to the webinar tonight. So before we begin, I'd like to acknowledge that our representative organizations are present on the traditional and ancestral territories of the Coast Salish nations. During this webinar, we recognize that individuals are connecting from across the province, and we want to recognize all of the traditional and ancestral territories from which you are joining us. We're thrilled actually to start the webinar with a video and address by Isabel McKenzie, the BC Seniors Advocate. So we'll go right to that first.
Hi, I'm Isabel McKenzie, Seniors Advocate for the province of British Columbia. Oral health is important throughout our lives, but it can be especially difficult to maintain as we get older. With issues relating to eyesight, dexterity, and memory, it can be challenging for older adults to ensure that they do their daily flossing and brushing. Keeping regular visits with the dentist can sometimes fall to the wayside as we age. Scheduling and getting to these appointments become more difficult. This is why advocacy and support from dental professionals such as yourselves is so important. Older adults need good oral health as much as anyone, and dentists are key to ensuring that they are not forgotten. COVID-19 created new challenges for seniors. Getting to and from the dentist's office became even more difficult, and residents of long-term care were cut off from their dentists for long periods of time. As we move forward, we must all do as much as we can to have the vital importance of good oral health for older adults recognized and ensure that seniors can access the dental care that they need. I thank you for your efforts in bringing this message forward, and I thank you for the work that you do every day, making sure that all British Columbians have bright smiles and good teeth, but especially for the care you've shown to the older adults of British Columbia and ensuring that they get the good dental care that they need in order to maintain their oral health. Thank you.
So it's my pleasure to introduce to you today the panel. I'll do a brief introduction right now, and I ask that as we start the conversation that each of the panelists do a little bit of a more in-depth introduction of themselves. So first we have, as part of the BCDA Geriatric Committee, we have Dr. Chris Wyatt, who is at UBC in the Faculty of Dentistry. We have Dr. Nicholas Tong, also from the UBC Faculty of Dentistry. From the BCDHA, we have Leah Thompson and Leda Zaleski. And from the Denturist Association of BC, we have Danielle Ramos. So let's get right to it. For all of our viewers, this is going to be a fireside chat style conversation. So if you can imagine us being around a table, being around a fire, having a cup of hot cocoa and having a conversation about this, that's what we hope we are able to bring to you tonight. So let's get started with the first question. So really, Isabel McKenzie spoke to the challenges to providing care in long-term care facilities that existed also before the pandemic. So before the pandemic, it is challenging to deliver oral care. Maybe we could start there and start with that question. And perhaps, Chris, you could start us off.
Sure. Thank you, Salima. And thank you for this wonderful opportunity to have this webinar across the three oral health professional groups. It's fantastic. I think this is the first time we've ever been participating at this level, and wonderful opportunity. I am director of the UBC Geriatric Dentistry program, and I'm going to answer your question in relation to the 18 years that we have been providing dental services from 2002 to that fateful time of March 2020, because time has certainly changed. So I'd like to highlight three challenges that I see, and I'd be really interested to see others on this webinar, see what they think about it. The first challenge, I think, is our patients and clients. They have changed over the years. Certainly, we've seen the average age creeping up now. Our average age of patients that we treat at UBC are 86 years old and older. They are increasingly frail, which means they're increasingly medically complex and taking many more medications than they used to. They are, on the plus side, increasingly dentate, which is wonderful, which means more people have teeth, and those that have teeth have more teeth themselves. So now we're looking at, when we started our program in 2002, about 50% of patients that we saw were dentate. We are up at about 75% now. The world is changing for the better because of the effect of preventive actions of these, of our dental professionals over the years of this cohort of patients. Unfortunately, with more teeth, there's an increasing level of dental problems, dental caries, periodontal disease, especially gingivitis, which means with an increasingly complex patient, this requires an awareness of appropriate and compassionate care. So there's a role for all of us. And certainly the demand for care has gone up. We know that families are demanding more and more care, especially dental hygiene services, because prevention is key. My second challenge would be support for care. Now, when we first started off way back in the day, 18 years ago, we were questioned by long-term care administration, by nursing staff, what were we doing there? These people were all edentulous. There's no point to have dentists and dental hygienists participating. And the world has changed for the better. We are welcomed as part of the team. And I keep emphasizing the team because we're working in a medical model. We're part of the medical team. Nurses, doctors, dentists, dental hygienists, denturists, all as part of a large team, including the care aides. So now we are welcomed, and we're starting to get referrals from our medical colleagues, which is wonderful. Within that challenge of support for care is the daily mouth care issue. I mean, it doesn't matter what we do to try and look after teeth and restore dentitions. If they're not being looked after on a daily basis by the care staff, that is an increasing challenge. And that's certainly what we've done over the years with our dental hygienists, educators, and delivery of dental hygiene services and educating care staff has still not made a big effect. And I still see that as a huge challenge. The last on the support is a lack of financial support to deliver care. Unfortunately, we're not part of the MSP or medical model. So we're fee for service. And that's a challenge for older adults, especially those on limited incomes. My last point, last challenge, is certainly there has been a real challenge on education of oral health professionals on the need to provide appropriate care for frail older adults, whether they're in long-term care or whether they're brought to community dental offices or dental hygienist offices. And I think there's been some good news on that front. And the BCDA has been so supportive on this. So is the Canadian Dental Association, I think so the BC Dental Hygiene Association, and I'm sure the Denturist Organization has as well. And we've made a difference. We have continuing dental education at the PDC, and we constantly see an increasing interest. I mean, on this webinar alone, we've got 200 people that are interested. That is wonderful. 20 years ago, that would have been a challenge. So on that same education front, to make a difference, we've increased our didactic education and our clinical experience education for our dental students and dental hygiene students at UBC, on the hope that the next generations of dentists and dental hygienists will take this role upon, because with an aging society, we actually do need this role. And I think we have had an effect. Certainly within our program, we have an increasing interest of young dentists and young dental hygienists actually willing to work within our program and to serve frail older adults. And I'm going to leave that on that positive note there.
Awesome. Thanks, Chris. So let's hear now from a hygienist perspective. Leah, I know you do a lot of work in long-term care homes. We'll pass it over to you.
Thank you. Thank you. I'm very happy to be here, and thank you everybody who's tuning in on a Monday night. Just to give you a bit of background about me, I've been a dental hygienist for many, many years. And then in 2010, I decided to start my own mobile dental hygiene practice. And so it's been 11 years now. Over the first few years, I slowly phased out of working in general practice dentistry, and I work solely in long-term care. I've been working for several years now. I do have a contracted dental hygienist, Martha, who I'm very pleased to have working with me. Between the two of us, we service several contracts that I have, mostly on the North Shore and also Vancouver and Squamish. And I have the pleasure of communicating with Sean Howe at the geriatric dental program, the UBC geriatric dental program. I communicate with Salima. I also communicate with Dr. Zulna too about just talking to these dentists and dental programs about patient cases and ongoing care. So that's just a bit about me. I agree with a lot of the things that, that Dr. Wyatt said. Definitely, I have a little bit of a, things to share about access to service, and mostly thinking just sort of from my practice and things that I see today. So access to service, for us to go in and see a resident and help out with their oral health, requires the family power of attorney or resident themselves to sign a consent form. If the person in the long-term care home is not on board with the program, that affects whether we can see that person or not, because as they are presenting, when a resident goes into long-term care, they're presented with a lot of choices of services, and they are, I'll maybe get to that later when we talk about, how to support families, but it's a difficult time and they're making a lot of decisions quite quickly. And so for them to be deciding whether oral health is important or not, it can be helpful for the person offering the service, who is the long-term care staff offering the consent form. It helps if they are, have a value dentistry and have a good education about what can happen with especially seniors and seniors in long-term care. And if that's a negative relationship to dentistry, then we see our consents go down and we are not able to go in and see that resident. So, as a little aside, a positive change or suggestion for that would be the ability for a dental professional to see absolutely every person in a care home, regardless of whether it's, a fee for service or consent form. Everybody should be screened and have an assessment done by a dental professional. And then the staff members in long-term care, because Dr. Wyatt brushed on that, and I would just say I have a lot of empathy and respect for their the difficulty of their job and trying to do that job on residents, some of whom are very difficult to do daily care for. So I just believe that asking them to do more than they are educated for is a big ask and quite difficult for them. Also, the same thing goes for management. When we have management that has a good understanding of oral health needs, then that has a trickle-down effect and they will motivate staff, and you can get a whole care home to have a culture almost of valuing oral health. And I notice when that does happen, and it makes a really, really good effect, and we see more consents and more people getting good health care. Yeah.
Awesome. Thank you, Leah. So what I'm hearing is the challenges in terms of providing oral care in long-term care is around the patients themselves being medically compromised. Chris mentioned that now they have even more teeth than they had perhaps 18 years ago. Also hearing that there's a lot around the staff, and if the staff have bought in, then it's a lot easier. Maybe I'll go to Dr. Tong Nicholas and ask, Nicholas, have you seen the effects of COVID-19? What have been the effects of COVID-19 in terms of providing care in long-term care?
Yeah, so hi everybody. I'm Dr. Tong, and it's nice to see all 156 of you. Thanks for joining. As Salima said, I'm a faculty member at the Faculty of Dentistry at UBC. I'm an assistant professor of teaching in the Division of Dental Geriatrics at UBC, and I'm also the program director for the GPR program, which is a hospital-based residency program here in the Lower Mainland. So I guess to speak to your question, Salim, about the effect that COVID-19, the pandemic, has had on the oral health of older adults, specifically those in long-term care, Dr. White and I recently published a study in Gerodontology, our peer-reviewed journal, specifically for geriatric dentistry, talking about the impact that the COVID pandemic has had on our program. And we talk specifically about the impact that it's had on the number of clinical visits, on our clinical productivity. And we also talk about the steps that we took to resume our practice in long-term care. So I guess for those that are interested, and if you'd like some nighttime reading, you guys can read our paper. But I guess, like the summary shot is we really compared the number of visits that we had from the period June to December of 2020. So that was sort of between phase 1 and phase 2 the wave 1, wave 2 of the pandemic, and that latter half of the year. And we compared that to the equivalent time period in 2019. So we were just comparing the number of appointments, the clinical productivity that we had in that time period, and we had a reduction of about 68% in that time period compared to the year before. I don't think that number is surprising to any of us. We had significant reductions in terms of the amount of dentistry we were able to provide our patients in long-term care in our program with the UBC Geriatric Dentistry Program. I guess on the positive note, we did talk about the phased and the measured approach that we took so that we could resume practice in long-term care. And a lot of that work, as Dr. Wyatt had said earlier, that was a collaboration between the Dental Hygiene Association, the BCDA, the Denturists Association, all of our oral health colleges, came together and wrote those policy documents to talk about infection control and talk about safe practice. And, for me, that's incredibly important because those things are the most important with our patients. Like those things that we talk about, infection control, yes, they're critical in private practice, but they're absolutely life or death almost, in long-term care. So the standard that I expect of our learners, or the standard I expect of our oral health professional in long-term care is, well, that forms the foundation of those documents. So perhaps I'll leave it at that. The COVID pandemic, as I'm sure none of the folks here on this webinar are surprised by, had a significant impact on the clinical productivity and our ability to do dentistry in long-term care. I guess as a bit of an insight, we were, when I first went back into long-term care to start doing extractions and doing restorations and start, doing dentistry again, I went back in with my GPR residents, our hospital dentistry residents, in June or July of 2020. So that was when I resumed practice. And this was like way before vaccines, way before everything, but we were able to go in a sort of a measured way. And we were able to prove to ourselves that we could do it safely. Once we proved to ourselves that we could do it safely, that's when we slowly started to expand to other parts of our program as well. So perhaps I'll just leave it at that. Thanks, Salima.
Yeah, Nicholas is being very modest, but actually he's right. I mean, we explored a model of care under a pandemic, with the increased PPE, the protocols, and everything under the sun in the most difficult environment that you can be in. And then the next step was we actually resumed our educational service for our dental students and dental hygiene students within long-term care using those same protocols. So in September of 2020, we were back in the clinical education side of this, which frankly, I was so pleased that we could resume the education for our dentists and dental hygienists in this environment. And we continue to do that over the pandemic, which is amazing, I find. And it just shows you that you can do this. You can work in this environment. Any dentist, dental hygienist, denturist can work in this environment if we just follow the appropriate guidelines and stay safe.
And if I could just quickly add, because we were on the North Shore and many of my contracts were with care homes that were heavily hit and for a long time, including the first one. I didn't see residents for 4 months and we lost a lot of our residents. And on a positive side, it was incredible to see the people who had it and survived. Some with incredible decay, but you know, probably not gum disease. I would love to see studies on that, but definitely the eye of the storm. And you know, we did our best from afar to support, and we saw a really nice welcoming when we came back in, and everybody was just feeling better about having been through it. Yeah, it was quite something.
Yeah, it definitely has been a difficult year and more, a year and a half. There in the chat window, a really nice story just from a member in Prince George. So he writes, in Prince George, we have a comprehensive program that serves all the homes in the city. Our program sees all the residents in the home for a recall, exam, and basic dental care, including dental hygiene care. It is delivered by dentists, hygienists, and a dental assistant, and our program is supported and paid for by Northern Health. We have streamlined our paperwork and consent process to make it easy to deliver care. Now, that's a great story. I know that Chris has more to comment on that, but first I'm going to ask Lita. Lita, in the work that you do in terms of your teaching and that and the experiences you've had, can you speak to in terms of for a a dentist who is in their own practice or a hygienist that's in their own practice, can you speak to what can we do in terms of supporting our elders in their oral care, whether they live in long-term care or not?
So thank you for having me. And as you mentioned, I do teach, and I have to say I'm envious of hearing Chris and Nicholas talk about being able to get into the facilities. That's the benefit, I guess, of being with the university associated with your own hospitals and so on, because we weren't able to get our students in. And I couldn't agree with you more that we really have to start focusing our education more on, care outside of the traditional dental setting, having our students better prepared to work on frail and complex clients. And so that's definitely something that we're trying to push through our program. But to answer your question, I think some of the things that we really need to push as an interdisciplinary team. So not just, the dentist, the denturist, the hygienist, but also the nurses, the dietitians, and so on. Recognizing, as again, Chris had alluded to, that we have to advocate together. I think we all recognize that there's a huge need, and us as a group being the oral healthcare professionals recognize that. I mean, thankfully, I think we are starting to see a little more awareness amongst the public in terms of, the systemic issues that go along with oral health problems, but not to the degree that we recognize them. And so I think, that's one of the main things that we have to push for, is to be included as part of the regular care team within the facilities, and have a seat at the table. And another thing, I think, just going back to what Leah had talked about, is that we have to ensure that we have the right profession or the right person in the right place at the right time. And, with all due respect to nursing and care help, if I was put in a situation where I was expected to do something that's within their regular scope, I would not, just because maybe I could do it, didn't mean I should do it. And I think that's what we have to consider as far as dentistry as a whole. So I think advocacy and working with a voice amongst all of the oral health professions to say, okay, we recognize there's huge systemic issues that go along with poor oral health, and the quality of life of the residents and elderly, and particularly the frail elderly, is really impacted by lack of care. And, again, what Leah was saying, that sometimes getting consent, if you have somebody that is maybe not very literate in the oral health to start with, it becomes downplayed. But it would be no different, than you would have the services of a dietitian, you would have the services of a physiotherapist, you would have the preventive health care from a dental hygienist coming in, the educated eye to make the referrals when need be. So I think that's probably the biggest thing that we need to push for now, is just to maybe get on our soapbox a little bit, because we're the ones that actually truly understand what the issue is.
Yeah. And you make some great points about advocacy, and we'll get to that because I think that's a really important topic for us to explore. But before we get there, I just wanted to ask if anyone had any comments about, the example that the member wrote in about Prince George. I think that,
awesome.
From that descriptor, it's amazing that they do have Northern Health paying for it, because at the end of the day, the savings would be there for the healthcare system. And to have all three, to have dentist, hygienist, a dental assistant, everyone working in collaboration, I think that's fantastic to hear about. So does anyone have any other comments on that sort of case study?
I think, I'll comment on that. It's the way it should be, right? And we've been advocating from BCDA about, really, there's a certain basic level of care, and it should be under the health authorities, right? And so Northern Health is actually further ahead than where I am in Vancouver Coastal. Even though in the past we have had some support from Vancouver Coastal, we still have some support from Fraser Health. But again, why isn't this across the whole province, right? And the other thing I think, sorry, Lita, that you touched on, which I firmly believe in too, is this is a different model, and it's more the medical model. It's more of a team approach. There's plenty of work for everybody. We're not competing in this environment.
That's right.
But however, in that medical model, you have to be part of the medical team. So if you're not within the team, you're seen as an outsider, and that has been a struggle, I think, for dentistry to get back into that medical model, because we weren't included at a national level to be covered under a healthcare system. And I think that's part of the challenge that we see.
Absolutely.
I agree with that. And I think also the education of the people in the building within the medical system, the mouth is separate. So it goes for that, and also their knowledge and experience.
It's so basic. I mean, our medical colleagues and nursing staff don't understand why we need to be paid for treatment. Like, well, how would we exist? We can't just do this for free. It doesn't work like that, right? So it has to be a model that will work for long-term care.
But that maybe is an option, though, too, is that when we do have care that's provided within a facility, that it is, I mean, residents pay for care, and that is their home. And so that may be something, like I say, they have dietary services, they have all kinds of other services that are included in the cost of their care. And I think maybe that is something that we should be looking at as well, that that the fee-for-service model is not maybe the best model. I believe particularly for, preventive care and so on, because oftentimes what can be feed out maybe isn't the care that is most appropriate at that time in terms of prevention and support, counseling, family support, and so on. So that is maybe something that we need to really take into consideration, that we're dealing with somebody who is paying for somebody to help them to be cared for and enjoy a decent quality of life. And obviously that's going to include the oral health as well.
Yeah. So in the question window, someone writes, and I don't know if we know the answer, but perhaps we have some thoughts. Why are there such differences between health authorities? So we talked about Northern Health, paying or supporting this this care, and I'm sure by them doing that, they've reduced the barriers between collaboration between dental professionals, but also the collaboration between dental and medical professionals. And so if Northern Health is willing to put their money where their mouth is, literally, then why is it that the other health authorities aren't there? I'm not sure, Chris, perhaps you would be the best from your experience to comment on that if we know the answer.
Yes, and I think the basic answer is they're afraid of how much it's going to cost.
Yeah.
And we did a project years ago, 10 plus years ago with BCDA, and looked at what would it cost to have a basic level of service for all residents of long-term care in this province. And the number came close to $1 million or something. That's a drop in the bucket in our healthcare system. So the numbers are not astronomical. And the reason they're not astronomical is that you're looking at appropriate level of care. We're not looking at bleaching teeth, putting porcelain veneers on, doing exotic dentistry. We're looking at a basic level of care, a safety net. And not all of the residents want the care. And that's okay. Maybe they have their own dentist or dental hygienists or denturists outside. That's perfectly fine. And so the actual numbers are lower than you would think on wanting the care and needing the care. It goes down a little bit. So it actually is quite manageable. And certainly BCDA has been advocating with our provincial government about this issue. But it's still a bit of a challenge because dentistry is perceived to be expensive.
I think one of the things too why it may work in Northern Health is because they're not dealing with the same population. They've been able to, I know, just knowing other parts of public health and so on, Northern Health has been able to do definitely more than some of the other health regions just by virtue of they have a large area, but they don't have the same number of people that say Fraser would have or Vancouver Coastal. So again, I think it's a nice luxury actually to have that they would be probably similarly funded as a health authority, but not dealing with the same number of people.
Yeah, and we're getting some great back and forth happening in the chat window as well as the question answer. So just a clarification that Prince George has a very unique situation. It's not across all of Northern Health. So somebody writes in that they work in the Peace area and there's not such a program, but agree that we need it province-wide. And so somebody else says that the reason they have it in Prince George is because they have great local advocates for dental health care. And there's been a lot of education done in terms of the healthcare system and the administrators that work there. So some great back and forth there. What I wanted to ask as well is when we're talking about, I think before we got to this this conversation around Northern Health, is that we were starting to talk about what can dental professionals do in terms of, if they're working in their own offices, what is it that they can do to help? And I think one of the things we've heard is advocacy, right? Talking about how important this is and talking about it with as many of your patients and other colleagues as you can, especially in the medical field. But what is it that that others can do? Any thoughts around that?
First off, I think we need to be clear that for every one person in long-term care, there's another 3 people living in the community with the same level of frailty.
Yes, that's true.
So we're not just advocating long-term care.
Yeah.
These are frail older adults that we need to look after. They're part of our society. And I think that's something that as a dental profession, we're becoming more and more aware of. And I like to see that our young dentists and dental hygienists are willing to look after these patients, because in the past they weren't.
I agree. It's great to see people interested. And I think we've already talked about advocating for the oral health of the resident. And, dental professionals being aware of why it is important. We know about periodontal disease being linked to systemic diseases. We know that the increased likelihood of death from COVID-19 is large, almost 9 times higher to die if you have gum disease and COVID. We know that people decrease their daily self-care once they get into care or become forgetful. They have an increased caries risk. And how I think general practice professionals can help is to lay groundwork for what we expect as seniors age, and if they go into long-term care, and start talking to the people in your offices. You're talking to the residents themselves or the patients themselves that may become residents, their family members. You probably have patients who are long-term care staff, nurses, general practitioners, all these people, and encouraging them to keep seeking dental care. If they become difficult in the office, please refer to us or recommend they continue care in long-term care, and not say it's okay now, we can't do anything, because in the disease process, a person may be quite combative for a while, and then they may get more relaxed, and you can do a lot more 6 months later, where you might have said, we can't ever do anything for this person again. So I think, and advocating for us who work in long-term care, and just the general support we've been speaking about before.
Yeah. It'd be interesting, Danielle, to hear your perspective in terms of elders and seniors that live in long-term care, in terms of any of the aspects that we've just spoken to right now from a denturist perspective. What have you been seeing?
Well, I found that lately I've been finding a lot of barriers getting into the long-term care facilities. I found that there's very lack of access to information to the workers in terms of the needs of a denturist, right?
And Danielle, I didn't get a chance to introduce you. You're also the executive director of the Denturist Association. So we're especially happy to have you here with us today. And you do go into long-term care facilities as a mobile denturist.
Yes, sorry, I'm going to introduce myself. My name is Danielle. I'm a denturist. I've been practicing for about 10 years and have focused mainly on my career in mobile dental services. So I do go into care facilities every day.
Sorry, I think I froze, but I worked with Danielle many times and other denturists, and they provide very valuable services to elders who may have partial or complete dentures. And over the course of years, the dentures, they may get loose or they don't fit well. And so denturists provide an invaluable service. And I know that you probably visit the long-term care facilities more than most denturists.
Yes, we do. We do go into long-term care facilities because in order to provide, denture services, we do need to see the patient for quite a few appointments. Mm-hmm. And so we are there, I'd say more often than a dentist, but you go and you see the patient and you go and you.
Yeah, for sure. So I think this, what we were talking about in terms of advocacy, we can go back to that. Isabel McKenzie did the address in the beginning, and we had reached out to her, hoping that she would do something for us. And the fact that she did was fantastic. But I think that, with having a seniors advocate, with having the pandemic shedding much more light on seniors, elders living in care and the situations that they're in, I think now's the time, which is the most important time for us to really make sure that these challenges are being highlighted, as well as solutions that there may be. And I'm wondering if anyone has sort of some thoughts around that piece.
Yeah, Salima, I can sort of speak to that a little bit. One of the, there's a few different elements that we're talking about in this conversation, and certainly what Chris and Lita and Leah were all commenting on about the funding for services, I think is a very critical piece of the pie, helping, us create a universal system, like a basic safety net that can cover, at least some preventative oral health services or some basic level of dental care in British Columbia, I think is critical and will remove an important barrier for some patients in care. The experience that we've had in our program over the years too is that the financial barrier is not the only barrier to care. The other, major perceived barriers that I encounter when I work in long-term care is, well, the family member, the son, the daughter who makes the decisions for the older adult is the substitute decision maker, the power of attorney. They have the concerns about medical complexity, about having a problem, a post-operative problem after dental procedures, all that sort of stuff. And for me as an educator, one of the we in our undergraduate DMD programs at UBC have a very tight curriculum, and we have a very limited ability to train people to work in long-term care. So, me taking someone that's freshly graduated from UBC, from the dental program, I would be surprised if they would be super comfortable working the day after they graduate proficiently in long-term care. So I guess the other question, the piece of the pie is, and I'm sure our dental hygiene colleagues have the same issue when they have a freshly graduated dental hygienist, will that person one day after graduation be proficient at working long-term care? Well, we haven't had this discussion that much in the last, 30, 50 years or whatever, but perhaps the realm of postgraduate training needs to come into this a little bit and figuring out, well, what do we need to train people on so that they can become proficient at dealing with a complex, frail older adult, which has a level of medical complexity and also dental complexity to them. Because, the issues that they deal with are not the same as our younger, healthier cohorts. So this gets into a much larger discussion about what that entails, but perhaps I'll leave it at that so I don't take over this conversation too much. Thanks.
I was going to say, as an educator, I agree. We already, our curriculum is packed with, there's no nice to know really in the curricula anymore. It's all need to know and, very heavy content that students are expected to capture. So yeah, I agree that we need to, change our focus a little more and again, recognize that each profession has, their own bailiwick and to make sure that we work to our strengths. And definitely it may be a matter of, for sure, post-diploma continuing education type of thing, but again, just even increasing the education generally, definitely for hygienists, because the science keeps coming and the evidence keeps coming, and what we do is more and more and more, and yet nothing seems to go away, and it just makes it a big challenge. So I know prior to COVID, when we did take students into complex care facilities, they found it incredibly rewarding, but it was also incredibly scary for them, like very, very scary for them. So the prep that you had to do just to, take them in to acclimate to the situation where you have very ill people, you have people with cognitive issues, the smells, everything that goes along with that, it takes time to acclimate to that. And we don't always have that time in our curriculum.
Lita, tomorrow I'm doing a lecture to dental hygiene students to prepare them for going on their long-term care rotation. And okay. I focus on specifically that, lots of slides. Get to see this now, get to know it now while you are in the comfort of your classroom or your home, because it will be online. And from a provider's perspective about solutions, I was just going to throw out there, improving national standards for long-term care specific to guidelines for oral health, allocating funding for dental professionals to be part of the primary care team, and ensuring that the oral assessments and screening is done by an oral health professional, and making continuing education mandatory in oral health. Yeah.
Salima, I also did want to circle back to your question earlier about what can private practice practitioners do to help with the health of older adults, because I know a lot of our 165 participants that are on the Zoom call are general dentists or dental specialists that work in private practice. Right. And, there's a book that was recently published by a geriatrician in the US. His name is Dr. Jason Karlowicz, and he wrote a book called The Problem of Alzheimer's. And he talks about, the story of Alzheimer's disease and about dementia in North America. And it's actually a really fabulous book if any of you are interested in the world of Alzheimer's disease. But he, and I talk about this because cognitive decline is a very common issue that we deal with in long-term care. He comments on how Alzheimer's disease, dementia, is not a disease of one person, but it's a disease of two or more people. So what he means by that is that when someone is diagnosed with Alzheimer's disease, well, there needs to be someone else who takes care of them. That person oftentimes is either the husband, the wife, the son, the daughter, or they hire somebody to take care of this person. So this is what he means. It's not a disease of one person, it's a disease of two or more people. The whole family gets involved. And I see lots of nodding heads. Well, so what that means for me, as what us private practitioners can do to help with this, well, we need to engage our patients in private practice, and any of them that have elderly parents or family members that have cognitive disorders. Well, we need to be, talking to our patients in a way to break down the barriers as much as we can, be friendly with them, tell them, educate them about the importance of oral health, and be welcoming of those patients into your private practices as much as possible. Be accommodating with changing appointment times. That can be a real big issue. Be accommodating with, there's a lot of things that we can do in the private practice setting to make it as easy as possible for the older adult to come into our practice. And we need to remember that most of the dental care that happens in our province does not happen with us on this call in long-term care. Most of the dental care that happens for older adults happens in private practices with general dentists. And well, they're valuable partners to us because they do a lot of the heavy lifting for us,
Yeah. And I know from my own experience that many elders who live in long-term care, they try to go to their community dentist for as long as they can, because that is their sense of trust and independence, and they want to continue those connections for as long as they can. And so you make a great point about, the private practice being aware of these kind of things, being aware of when it is that you need to bring in a family member in terms of informed consent. Perhaps the patient that you've had for 30 years, perhaps there is a time when you need to involve a family member for a variety of reasons. And so I think, Nicholas, you bring up a really great point.
And, that's something that I teach my residents all the time. The person that the patient, and most importantly, the family is most comfortable with is the dentist they've known their whole life.
Yeah.
Not some new guy like me who's coming in and seeing them for the first time, but as someone that they've known and the family has a relationship with and has the comfort level with. That's very important to the family. Which ultimately, and oftentimes they're the ones that make the decisions about where they get care and who they get care with. So don't underestimate your relationship with the family, and don't underestimate your relationship and your past history with these patients, because patients and families really value your expertise.
Yeah.
I think that brings
Salima,
up.
I just wanted to comment. I think Lisa and Nicholas had the same thing as this idea of creating a comfortable environment. So we know if we want to make a difference and have dentists and dental hygienists and dentures serve this population, we have to have a comfortable environment so they can, receive the education and the clinical experience. As long as it's a positive experience, there's a greater tendency for them to do this. But I also think we're missing out a little bit, that we should be actually offering this at more continuing dental education for those dentists, dental hygienists, and dentures in the community. I think would like to serve this population either within their own practices or in long-term care if they knew how to. So we've always welcomed dentists and dental hygienists to participate within our program at UBC, even if they want to just come for a day, just to see the environment. But if we had a way of doing that, I think we could make a big difference. But again, it's this comfortable working environment, a supportive working environment. Yeah. And it's also the same with the families, right? And their patients. And the families' patients. Yeah.
You make such a great point, because I know that all of us are from the Lower Mainland. So in the Lower Mainland, there are a lot of us who provide this kind of care in long-term care. Sorry, Lita, I know you're not from the Lower Mainland, but close enough. But I know that in further out areas, and I speak from experience with regards to Kamloops, so there, we get phone calls all the time where there are family members asking that, does anyone come to long-term care homes? And so there's many cities within British Columbia where there aren't dental professionals. So when, we talk about collaboration and all the rest of it, well, that doesn't even exist for them. So Chris, you make a very, very important point that there are many elders who live in care or who live at home and aren't able to get to the dentist, who are housebound, who don't have that care available to them when they need it. That's a great point.
That was the point I was going to make, that not everybody's ambulatory and not everyone has family support. There are people living in long-term care that, they get consent from the public trustee. There isn't anyone to take them. So I think that's something that also you have to take into account, that their needs are just as great. And just speaking from experience, because I've had the experience of having both of my parents in long-term care in two different facilities because of two different, levels of care required. And yeah, just even to try and coordinate that if you don't live in the same place, and to try and get somebody to take them or to assess to see whether, like I'm from far away telling them that I think that they need to be seen, and they're, oh, well, it's not a problem, and so on. So again, I think the need to have people that are well versed in dentistry to be able to make those decisions, but then have something in place to especially when they require dental, like secondary or tertiary care, to get them, how do we get them into the private dental offices?
Lita, that's a great point. And we've proven that you can do this. So we took our geriatric dentistry program and we went over to the island. We went to Courtney Comox, and we hired a certified dental assistant to help as a sort of a coordinator. And linked up, we had 3 dentists and a dental hygienist, and they created a team which we looked after 5 long-term care facilities over in Courtney Comox. And because we supported them and showed them how they could do this, it worked for as long as we were willing to support it. And that was the problem. But what we were trying to explore, and this was another project funded by the BCDA, is that could you have a dental health or an oral health coordinator for each health region, and her or his job would be to help coordinate care. So the patients in long-term care could be better connected to dentists, dental hygienists, and denturists to facilitate care, because the system is complex.
Mm-hmm.
And if you, as you described, if you've got a mother or father in long-term care, how do you even know what services are available and how to get them? There's nothing out there.
Yeah, these have been great conversations that we've been having. I know that, we wanted to cover a lot of ground in these conversations, and I think we've accomplished that. Chris mentioned at the beginning that this is an incredible collaboration between the denturist, the dental hygienist, and dentist, and that is something we need to be proud of as well. And we hope that this is a reflection of the work that we do together in long-term care for our frail elders. So on behalf of the BCDA, I wanted to thank each of the panelists for sharing with us your time and your knowledge and your expertise and your experiences. It's been a great conversation, and wanted to really thank the participants on this webinar for staying with us throughout. It's always interesting to see how many drop off. It's sort of a gauge of how interesting the conversation is. And I'm happy to say we actually increased participants as we were going along. So it shows how great each of you were in terms of your contribution. So thank you all very much. And to all our participants, have a great rest of your evening. Thanks so much. Bye.
Thank you.